Good afternoon, everyone. My name is Nafis Anjala. I'm President for Society of Spinal Research, Back Pain Research, and I'm joined by my colleague, Alan McLean, and we have a session set up for you this afternoon on spinal cord injury as well and generation. Alan, did you want to, have you got your camera up?
Yeah, hello.
Hello.
Hello, Navis, can you hear me?
I can indeed.
See me shortly. Here we go.
Excellent.
Apple is trying to protect me desperately to stop anyone. Let's see if this camera is going to work. So just to fill in, my name's Alan McLean. I'm one of the consultants in Glasgow. I'm trying to get my camera to operate and it's not. Navis, my colleague, and to everyone here, my colleague Ali Jamous, who's one of the very senior doctors in Stoke Mandeville, sends his apologies. He was supposed to be chairing the meeting today, but unfortunately can't is having IT difficulties. But I recognise him being protagonist popping up in the various windows here. I'm still being blocked by Apple, who are determined to preserve the privacy of my office here. So I'm going to keep clicking on camera. And I will introduce the speaker. Well, Navis, Navis, if people can see you, are you happy to? Well, I'm happy to introduce the speakers. Actually, who would like to go first? Waggy, were you going to go first, or was you going to go first? You're muted, Waggy. Well, while we're waiting for Waggy to unmute, I'll just say a few words. My name's
Mr. Chairman.
So my name's Alan McLean. Welcome to this session. I'm very grateful to the organisers for inviting me. I work in the National Spinal Injuries Unit in Glasgow, and this is a subject very close to my heart. We're very acute in Glasgow. We take people with 1 or 2 days of injury, and this is constantly a question: do we or don't we operate? And I'm delighted to have Waggy with us, who's a very experienced professor from the Midlands Spinal Injuries Unit in England. And I think we'll launch his presentation first. Waggy, can you go ahead and launch your presentation? Or Henry, can you press the right buttons for that? Thank you.
Members of the organizing committee, delegates, I'd like to thank you for inviting me and for your interest in the subject. I'd also like to acknowledge all those I've learned from in the last half century, and in particular, Sir Ludwig Guttmann and Dr. Hans Frankel, whose contributions to the field of spinal injuries are at least as important today as they have consistently been in the last 7 decades. Having developed his model of service delivery and the expertise in managing the unstable injured spine together with the multi-system physiological impairment of patients with spinal cord injury, Guttmann demonstrated quickly that all the complications of spinal cord damage can be prevented. Each and every impairment can be optimized, and each and every disability can be minimized in order to minimize the impact on the patient and the family, and to enable the patient to achieve maximum independence and long, healthy, productive, dignified, enjoyable, and often competitive lives. Guttmann made 3 important further observations: is that a significant number of patients did recover neurologically, various degrees of neurological recovery, without any intervention and irrespective of their radiological presentation. The neurological outcomes following lamellectomy were condemned by Guttmann, who was a neurosurgeon himself, because of the poor outcome. And he also noticed that some medical and surgical complications can be responsible for neurological deterioration. Having personally witnessed neurological deterioration or delay in recovery or non-achievement of expected level of recovery with each of these complications when severe, I coined the phrase physiological instability of the spinal cord just to highlight the fact that unlike the intact spinal cord, the damaged spinal cord can be further damaged by insults that occur because of the poor management, poor non-operative or surgical management of the patient. In the mid-1960s, Hans Frankl studied the neurological progress in 612 patients who presented to Stick Mendel Hospital within 15 days of injury. He showed his results in his famous Frankl classification, which incidentally remains today the most fit for purpose classification to communicate neurology or neurological presentation of an individual or groups of patients at any point in time following injury. So he expressed these results on the basis of an observation he made that long tract sparing correlates reasonably well with the neurological recovery. So he classified his patients in 5 groups, as you probably all know. What he found is that those who presented in the Frankl B group without any motor power at all below the level of the lesion, 60% of those and 70% of those who presented in Frankl C, negligible or more, slightly more than negligible power, or at least non-functioning power in the lower limbs, would recover significantly to actually stand and walk with or without arthrosis. He also found that those who present with useful motor power will 40% of those will recover, altogether 40% of those will recover functioning motor power to support the patient standing or walking. I have personally interviewed, examined and reviewed almost every patient in the Frankl study. I have confirmed his finding as well as made one more observation, and that is the sparing of pinprick sensation is usually followed by better outcome than the sparing of other modalities or the expression of the reaction to a pinprick as a deep pressure or a pulse. This finding was confirmed by Foreman and published in Injury in 1989, and then a number of other groups of people. Both Frankl classification and mainly Frankl classification has been verified, confirmed by a multitude of groups of spinal cord injury specialists in the UK, in Europe, and in Australia. In the late 70s, early 80s, unfortunately, with the development of the CT and MRI scan and their use in the management of spinal injuries, a number of so-called indications for surgery were expressed. There was one legitimate indication, probably from concerns and the assumptions that some of the radiological findings could be actually detrimental to the neurological outcome. Unfortunately, for the last 40 years, there has not been any evidence of that when patients are managed adequately. There were either imagined or indications. I'm not going to go into details, the slides will say it all, and based on beliefs and based on figments of imagination. When I was appointed in Oslo Street, Robert Johnson Orthopedic Hospital, then the CT scan and MRI were installed, and I had to choose between continuing to manage patients by a method of known and measurable outcomes while testing the significance of the radiological changes on these new methods of investigations, or indeed move on to operating on every patient with biomechanical instability, canal encroachment, or cord compression. Well, I decided, with the support and under the watchful eyes of my colleagues, to test the significance of these radiological findings and use the prognostic indicators of recovery and compare a kind of outcomes in the presence and absence of these radiological findings. I'm going to present a few patients here, and none of the patients has had any surgery, decompression, stabilization, or realignment. They all missed their window of opportunity for surgical intervention, and they all recovered not only neurologically, but full mobility of their spine without any pain. So this was one of the first patients who admitted in 1987 in Frankel D, under 3 months following injury. She has actually recovered completely. I am not going to say much on the X-rays or CT scans, but as you can see, she has managed to stabilize with a kyphotic deformity as well as some residual canal encroachment. The canal cleared spontaneously a great deal. I am moving on now. It's almost 33 years since her injury, and she has maintained this recovery. For those who actually believe in the active conservative physiological management of patients with spinal injuries, here are the radiology of this patient who was admitted 1 day following the injury and has recovered as good as the previous one. Cato, who's currently the professor of spinal injuries and rehabilitation medicine, studied our population of patients, and as you can see, there is no correlation between the degree of canal encroachment, the neurological presentation, or the degree of neurological recovery. He also looked into 63 cases with cervical injuries only in B, C, and D, and the same outcomes he found also were irrespective of the radiological presentations. As you can, this was published in Spine in 1996, and the previous one in Neurotrauma in 1993. As you can see, those who recovered significant motor power from no motor power at all are those who have retained pinprick sensation. This patient temporarily deteriorated and recovered within 2 years from injury to a segment or two below his original injury. And now I'd just like to show you two of the cervical injuries. And this lady, 58 years old, had fallen out the bed in 2004. And as you can see, she came to us 2.5 weeks following injury without any realignment or decompression or surgical stabilization of the time. She was said maybe to be in Frankel B, but by the time she arrived anyway, she was in Frankel C. So assuming that she was in Frankel C from the very beginning, she recovered the way you have seen her recovering, both neurologically and the flexibility, painless flexibility of the spine without any intervention. This is probably the last patient I'm going to show, and he was admitted to my department one day following injury in a Frankel B group with a C5-6 dislocation. Within 4 months from injury, he has regained almost full motor power from no motor power at all. Okay, without any intervention again. And these are his radiological pictures. He's got a residual, well, the subluxation, which has healed in that position. Still a little bit of cord compression. And now it is, the video was 16 years following injury, still working as a lorry driver 32 years later and maintaining his. This is work in progress, and these are the findings I have at the moment. It hasn't been published yet, but I plotted the latency between injury and the first flicker of recovery of patients with injuries presenting in Frankel B. If you would have noticed here that it may take up to 35 days in the cervical spine, 45 days in the upper thoracic, and about 18 days in the lower thoracic from injury for any flicker of movement to reappear. The median is 10, 8, and 3. So just reflect on how difficult it would be to actually measure whether we have helped or hindered the recovery of this patient, of all these patients. Again, the fact that they have recovered to about 70 to 90% of the normal motor power from being Frankel B, you can see we need to at least prove that degree of recovery. So this is just to demonstrate that at about 7 weeks, any patient who has more than 20 points motor score at 7 weeks or more after injury will probably at 1 year have a motor power of 70 to 90% of normal. I also documented the ambulation, and as you can see, 68% of the patients will be walking without any support or with one stick only at 1 year following injury, and 73% at 2 years. The number who use 2 elbow crutches will not change much. However, less than 1% of the patients will use a wheelchair intermittently after 2 years. The neurological outcome of active physiological conservative management of complete injury, and by active physiological conservative management, I mean 4 to 6 weeks of bed rest, during which all the multi-system physiological impairment and malfunction is being managed, followed by 4 to 6 weeks of bracing while the patient is rehabilitating. So without any interventions of the spine, we found 2 factors: that if the neurological level is higher than the bony level, the neurological level will improve to at least the bony level or below. And again, if there is pinprick sensory sparing in the zone of partial preservation, with or without any motor power at all, the motor power will recover or will increase significantly. Yes, about 10% of the patients at 48 hours from injury ascended their level by 1 or 2 segments, and they have all recovered them. Ladies and gentlemen, I do not want to keep on ranting about early mobilization. The slides that I have shown before explains in detail why I am stating that it is all the benefits are a figment of an imagination. And sadly, none of the claimed benefits have been audited and compared to the outcomes of conservative management, adequate conservative management. And I would put it to you that the hospitalization time and every other complication to be said to be reduced is actually prolonged after surgical intervention rather than shortened. No patient below C4 has been referred to an intensive care unit following active physiological conservative management unless they've had multiple severe chest injuries, or indeed they have had COPD prior to their their injury. And we have known for 55 years, 65 years, whatever, the effects of a verticalization of patients in general in spinal injury patient, and the effects on blood pressure, vital capacity, and possible effects on perfusion of the spinal cord and neurological outcomes really cannot be said to be better by actually mobilizing the patient in the spinal shock. We've had 2 audits of pain in the population of spinal cord injury in Oswestry, and as you can see, the incidence of pain is less than 10% following active physiological conservative management. The current accepted incidence on which an industry has been created is, I believe, 60%. Anyway, so what does actually surgery do? I expect, if you're confident not only in your own skill, but in the skills and knowledge of the team who helps you look after every system impaired by the cord damaged, you will, and you manage to avoid any of these complications, all these complications, then you will probably have as good outcomes as active physiological conservative management. I've seen neurological deterioration, delay in recovery or lack of recovery from each and every one of these complications many times during my career. So what are our indications of spinal injuries? Stabilization mainly is neurologically intact patients with biomechanical instability can be sent home. Pure ligamentous injuries without any bony injury at all, they take longer to heal, and we usually operated after the 3rd or 4th week when the spinal cord has physiologically maybe settled a little bit. Obviously, neurological deterioration, we give the patient the choice and explain depending on the prognostic indicators of recovery. We've had patients neurologically deteriorate but maintain their pinprick sensory sparing and recovering more than what they have. I can show you some if I had the time. So yes, in general, but we do not know up till now what is the outcome of surgery in patients who had neurological deteriorated and who have been operated on. Mentally challenged patients and uncontrolled epileptics, you cannot trust that they will comply with a period of 4 to 6 weeks in bed. So my conclusions are that you can safely miss the window of opportunity, which I do not believe has proven to be existing in humans, but we can debate that. My main message is that you, for these outcomes to be reached, one needs to manage every system of the body affected by the cord damage at least as equally well as the spinal cord itself and the spine. Pinprick sensory sparing is a good prognostic indicator. As I mentioned, recovery can be predicted to a good extent at 7 weeks. And sadly, I have to say that the radiological findings, all of them, malalignment, cranial encroachment, coarse compressions on CT, X-rays, and MRI scan, are of no prognostic value unless the patient is poorly managed non-operatively or surgically. Early mobilization, I think I said enough. But yes, the complications of bed rest are complications of the poor management of the patient in bed and not the bed. And as I said, Gutman demonstrated, and for 70 years we've been demonstrating that all complications can be prevented. Ladies and gentlemen, there is no elevator to success in the business of treating patients with spinal injuries. One has to spend the time, the energy in managing the patients and ensuring that the staff who manage the patient with you are equally knowledgeable and prepared to spend that time. And ladies and gentlemen, I'd like to thank you for all the issues of the Journal of Paraplegia, where all these original literature has been published, and the Gutman 2 volumes I've managed to digitize them and put them on the Spirit Charity website, and they are accessible free of charge. I would urge you to not to ignore the old literature, and because I think it will be very helpful to us. Thank you.
Thank you very much, Wagi. That was a pleasure to hear. Of course, that's a pre-recorded talk, folks. So we'll just give it a couple of minutes to see if Wagi can join us in person to discuss a couple of the comments that have already appeared in the moderating chat. I'll just turn over to my co-moderator. Nigel, are you able to filter the chats as well? Oh, we've got Wagi here. Excellent. Hello, can you hear us okay? Welcome. That was absolutely delightful. I've just been thanking you publicly for taking the time to put together that beautifully prepared talk. A huge amount of experience, of course, that you've shown over the years, you and David Jaffe and co, showing that am I right in saying people with incomplete injuries, if you lie them flat, the majority get better without doing anything to them surgically? Is that your basic argument over the years?
Yes, absolutely. And what we do not know is that whether all the so-called complete injury in the first 24, 48 hours are complete or not. It's very difficult to get a very accurate neurological examination, and during the stage of spinal shock, you may not have any sensory sparing at all.
Thank you, Aggie. We've got a couple of minutes before we bring on you. So David Cummings just asked there in the chat box, why do, well, I hope you can answer this because I can't. Why do all centres not follow an agreed national consensus on bed rest and spinal cord injury? That's a very brief. You can just discuss that in about 30 seconds, I'm sure. But can you give us a minute over why that's been so difficult?
Less than a minute, because in spinal injuries, I'm afraid there has not been a homogeneous training in the field of spinal injuries in the centers that have treated patients conservatively. There has been a lot of changes about 20 in the late 90s, and spinal injuries it took me 13 years to be able to be given the license to kill, so to speak, and now it's all being squeezed in is it a year or 2 years or 6 months, and there are pressures to reduce it further.
Thank you. It's a very good point, actually. I mean, just briefly for the audience who are maybe not British or maybe not so old, certainly in Britain, it used to be a surgical speciality. It was recognised as a subspeciality, and a great deal of training involved. And then, of course, in the 90s, actually, ironically, to align us with European legislation, it went part of under rehabilitation medicine. I think introduced a different bunch of doctors, but different training regime for good and bad. I think I was an outsider. I didn't come through either surgical or the rehab pathway, so I can talk freely about this. But Maggie, that's absolutely splendid. I'm hoping Nigel is teeing up our next talk, and I'll introduce the next speaker, Nigel. Is that okay with you? So before we start, I'll just introduce Joost, who's with us, I know, today. And Joost, we're very lucky to have Joost in the spinal injury community in Europe and in Britain. Joost is the chair of the Scientific Advisory Board of the Stoke Mandeville Spinal Research Group, and he is actually a doctor in training and a proper scientist with a PhD who's worked clinically and in research, now works for private commercial pharmaceutical biotech company in Belgium, but very closely involved in spinal research now for about 15 years. I've known him, and very closely involved in very large-scale projects looking at spinal cord injury. And well, I'll let him speak for himself. Joost, over to you. I think Nigel's going to play the tape, I think they call it. Thank you.
Good afternoon, everyone. I would like to thank the organizers for giving me the opportunity to present an evidence update on the role of early surgery after traumatic spinal cord injury. Here are my disclosures. I'm one of the co-principal investigators for the Skype home study, which results are due for the second half of this year. So in the next 20 minutes, I will cover the following highlights. I know it's a topic we can talk many hours about, but I have to limit myself to only 20 minutes. So first, a quick introduction on the time is spine concept, then a very quick review on the evidence that have been published so far, systematic reviews, meta-analysis, followed by the original studies. And then I will continue on the way how we measure recovery in traumatic spinal cord injury, and ask the question, are we doing it the right way, yes or no? And finally, I will present the results of a recently published pooled analysis that has been published in the Lancet Neurology last month. And I will close with conclusions. So first, time is spine. So this concept or the mantra is gaining traction in the field of spinal trauma and spinal trauma surgery. And it's primarily being driven from the group from Toronto, Canada, but it's also spreading beyond that. And on the right lower corner, you see a paper that was published in November last year, where there's the risk of litigations are being highlighted. Well, the authors state that spinal cord injury may at some point be considered as a surgical emergency, and hence the surgeons who are treating spinal cord injury may be at increased risk for litigations. So it's a serious development that we are witnessing. And the question then is it the right movement, and is it based on the right evidence? So where does time is spine come from? Well, it is sort of a parallel to the development that we've seen in stroke, where the dogma time is brain was coined in the early 90s. But interestingly, over time, 25 years later, after the editorial by Dr. Gomez, capturing this dogma, 25 years later, there was a much more nuanced approach where Dr. Gomez basically says it is clearly evident that the effect of time on the ischemic process is relative. So there's much more components are involved. So it's not only about the timing that is a predictive factor in the recovery after stroke. So the question then is are we witnessing a same tendency in the time is spine concept? So last year, the Toronto group published a narrative review, and clearly it's not the case that we got a very clear, nuanced approach to the topic time is spine. So this review covers the preclinical data, which I will not present in much detail now, but the authors state there's robust basic science data supporting the concept time is spine. And also looking at the clinical literature, the group says there's strong evidence to support the time is spine concept. This is in contrast to what I and my colleagues published back in 2013. So we published a systematic review, a meta-analysis, and we concluded actually the opposite. There's no robust evidence supporting early spinal surgery after traumatic spinal cord injury, and it was basically being driven more or less by the finding also that we found publication bias as displayed in this funnel plot on the right hand side. But that apologies. So that was back in 2013. And the Toronto paper that we just mentioned was published in 2020. So maybe things have moved the right direction in the last 7 to 8 years. Now let's have a look at the most recent papers. So I conducted an update of the literature review early this year. And I would like to first touch on the systematic reviews and meta-analysis that have been published. And we can clearly see that, almost a dozen of reviews have been published, with a vast majority saying, yes, early treatment after spinal cord injury is recommended. And of course, there's a heterogeneity in terms of population and the early versus late threshold. With different focus on traumatic central cord syndrome, cervical, thoracic, or all the studies grouped, as well as early being defined as within 24 or 8 hours. But on the whole, there's this overwhelming green column saying yes, surgical intervention is recommended on the earliest convenience. And some papers do make more nuances to this. Some only say, well, there's evidence for cervical spinal cord injury within 24 hours, which is basically driven by this TESCAS data. And another study says, well, if you look at the cervical spinal cord injury, then only the Asian impairment scale grade A would benefit. There are a number of strengths and weaknesses in these systematic reviews, which I will not go into too much detail. But again, the key message here is, yes, there's a big body supporting the timing spine concept. Now, do we see the same in the original studies? Most likely, yes, but I did have a more careful look at these studies. So in our original meta-analysis published in 2013, we had 13 papers reporting on neurological outcomes. And since then, 29 additional papers have been published. So lots of new evidence is being generated on this topic. Out of these 29, 18 were retrospective studies. 15 of these 18 reported a positive impact of early treatment. 3 studies did not show a positive impact. 1 only had a follow-up of 7 days, which makes sense to not see a dramatic impact. Another study looked at thoracic spinal cord injury, which primarily included Asian impairment scale A, so complete lesions. And this study from Murnau did not show a benefit for thoracic spinal cord injury. And there's another study from China, a large study that evaluated the timing within 72 hours, defined as early as opposed to the late after 72 hours. However, in the study, the Frankel classification was used, and I see that as a limitation. So more on the retrospective, limitation in general is the way how to retrieve reliable neurological data. And I would like to show one slide that really captured this. So this is a paper published last year, 2 years ago, by the group from Plymouth. And this is a very nice paper where there was a retrospective review of the neurological examinations being performed at this site. And in total of 96 patients were identified, and the chart did show incomplete reporting of motor and sensory scores, which are critical for determining the level of injury. And more related to that, the Asian impairment scale grades and the severity were only reported in a minority of the cases. Now, these can be retrieved or calculated based on the motor and sensory scores, so this is the most important bit, but these missing values are of big concern, as well as the actual accuracy of defining the Asian impairment scale and the complete-incomplete rate. So what we see is that 3 out of 4 patients are incorrectly classified as complete or incomplete injury and the Asian impairment scale rating system. So hence the provocative title that retrospective neurological data provide more holes than Swiss cheese. To move on to the prospective studies that were included in the last update, we did see 6 studies that reported positive outcomes. All studies did report on prospective Asian impairment scale data, whereas only 2 did report on the motor scores. And interestingly, those two studies did report on negative outcomes, not favoring early treatment. So there's this randomized controlled trial from Iran, which is an interim analysis. Then there's also a study comparing within 4 hours or within 24 hours. So this is a ultra early versus early comparison that did not show any difference. And then there's this study that had a look at the age impairment scale grade A to C for cervical spinal cord injury. Two other studies were published. The registry, the Rick Hansen spinal cord injury registry data showing positive impact of early treatment, and a pooled analysis, which I will cover later on. So 29 studies with 15, 6, and another 2 studies reporting positive impact of early treatment. I know it's a very top-level review, and some might even say, well, you know, are all lights on green for early surgery with these evidence accumulating? I would say not so fast, and that's basically for the following reasons. It comes down to this question: are we measuring recovery in spinal cord injury? Are we doing that the right way? And as I mentioned, the age impairment scale is being used in all of the prospective studies, and what value should we attribute to that? The title of this slide says it all. It's a bit of a bold statement, but in terms of an outcome measure, the age impairment scale is overrated, in my opinion. And that's because of the 4 following arguments I would put up. So the first one is the age impairment scale grade improvement, which is basically, you know, the conversion grade is quite often being considered as a primary outcome in these studies. But this conversion or improvement does not automatically mean that there is a motor score improvement. So there may not be any functional benefit to it other than to see a shift from age impairment scale grade A to B, which is basically an increased sensation only to the sacral segments. So in terms of recovery, that does not mean a lot. Similarly, for improvement, it does not equal functional improvement for every improvement that we see. So a conversion of 1 grade can be highly meaningful if we see a conversion from C to D or B to C, but it may not show any functional improvement on the functional outcomes if it goes from A to B, as would be the case for ambulation outcomes. So there are serious interpretation difficulties there, and what does this conversion rate mean? To continue, the age impairment scale grading system is very complex, even for experienced raters, and we know that the age impairment scale grading system also displays flooring and ceiling effects. I've got a few slides on the last 2 bullet points. So the first of the 2 bullet points is about the misclassifications. This is a very nice publication from the SCI group, published in 2015. And the SCI is a network with highly dedicated rehabilitation specialists who know how to do a neurological examination, one would say. However, this study shows that there are clear misclassifications for the age impairment scale B and C. So these are difficult age impairment scales to recognize and to classify as such. We also see flooring and ceiling effects. The flooring effects is what we see in the age impairment scale A, and also the ceiling effects in the age impairment scale D. So for age impairment scale grade B, we see a much more diverse recovery spectrum. So this is really also having an impact on the likelihood of age impairment skill conversion. So to conclude this appraisal of the age impairment skill, I would say yes, this skill is overrated. It has many limitations, and there are many other avenues to demonstrate neurological and functional recovery, and it can be done by basically the same examination, but utilizing the total motor score, the upper extremity and lower extremity motor score, and functional outcomes like the skin, which provide much more meaningful information. That brings me to the last study I want to capture. This is the pooled analysis that was published in February this year, which shows that yes, surgical decompression within the first 24 hours is associated with neurological improvement. Now, what does this pooled analysis consist of? It consists of 4 data sources: the Nectin Spinal Cord Injury Registry, as well as the NESCIS-3 study and the SIGEN trials. And these 3 studies are being pooled with the only surgical, large prospective surgical study that we know to date, and this is DESCIS. And all these patients were pooled together to see whether the surgery has an impact, positive impact, yes or no, with the cutoff being 24 hours. This is a baseline of this study. As a remarkable balance in terms of early versus late surgery when comparing the age impairment skill grades. But there's a slight difference a slight difference indicating that the early surgery group has a bit more severe injury as compared to the late. But this has been corrected for in statistical approaches. Here we see the baseline again, and we see that the late surgery or the early surgery is in favor, is showing better neurological outcomes with 4 total motor score points favoring early surgery. So then, reading the paper, I was surprised to see total motor scores for this DESCIS, and there's a red flag, and I was not only surprised, I was actually really concerned to see motor scores in this pooled analysis, whereas they were not reported in the original publication. And as you may recall, that the primary outcome published in this original publication was the 2 grade age patients, all in the late surgery group, that were added to the 313 patients that were published in the original DESCIS publication. More so, there were 2 other concerns I had with the pooled analysis. They included NESCIS-3 data, only captured 14 or 15 muscle segments, and not the 20 that are being used in the ASIA examination. And the authors do not explain how that had been corrected for, as this may really have a big impact on motor score changes and analysis like presented here. And lastly, the Nectin registry also included postoperative baseline neurological assessments, which is highly questionable if you really want to understand, does the surgery has a positive impact, yes or no? So you want to have a pre and post-operative assessment. This is not unique to the Nectin registry. We also see this in the MSKI and Rick Hansen Spinal Cord Injury registry papers. So with that critical appraisal of this pooled analysis, I think this concern of publication bias that stands out to me, and that's something that we are very conscious of for the SkyPoem study. This will be published, as I said, in the second half of this year. It almost has almost 300 patients in this, and full transparency is our top priority. Now, the final slide, conclusions. Despite the rapidly growing number of original publications, conclusive evidence is lacking. The vast majority of retrospective studies show neurological benefits for early surgery. However, as I showed, the value of that is, in my opinion, only minimal. The Age Impairment Scale grading system is useful as a severity descriptor, but not as an outcome for recovery. Unfortunately, the relevance of neurological level of injury, motor score, and other neurological prognostic factors are increasingly recognized in prognostic studies. So this is a really good development. But as of to date, no large prospective study favoring early surgical treatment has been published to date. Also keeping in mind the criticism for the SCI study as also became clear in the pooled analysis. So publication bias appears to be an increasingly worrying phenomenon in this field. And finally, I believe that time is Pine slogan really thwarts the clinical equipoise in clinical research. And I really hope that the developments that the time is brain has seen will also be the case for the journey that we are witnessing for the role of early intervention in spinal cord injury. With that, I close this lecture and I hand over the word back to the moderator. Thank you very much.
Right, thank you very much. Just indeed, we'll just give a couple of seconds for comments to appear. They're a very interesting talk. Just while we wait for a couple of comments, and I hope Nigel's going to help me moderate these.
Yep.
One striking thing is with the Asia examination that you and I are familiar with, which has been around for many years now. But you mentioned in your talk there it's really pretty complicated to do, and I certainly, in our unit, I've been doing it for 20 years, but it takes me and the junior doctor really about half an hour to do it properly in a conscious, undistracted patient. We're getting people in within 24, 48 hours of injury. They're sometimes still drunk, they're under the influence, they've got distracting injuries. Do you think the time has come for us to find is there a better tool we can use in the acute setting than the complex Asia form? It's perfect scientifically, but very difficult in practice. Do you have any thoughts about that, use from your vast experience now of MSCI and other scoring systems and studies? Very grateful to hear about that.
Joost, you muted, Joost. Oh. Joost, did you hear the question? I think. Oh.
Apologies. It looks like Joost is having a little bit of trouble with his microphone. May I suggest you move on to potentially another question, and we'll come back to Joost on that. May I also just say that the session is overrunning ever so slightly, and we can extend for another 5 minutes afterwards to finish at 10:02.
Beg your pardon, I thought we had 4 minutes.
Yeah, I was going to add to Alan's question, really, I don't know whether Joost heard it, was whether something that is much more user-friendly and simple and functional is to go back to ideas around Frankel. Or was that what?
May I come in?
Just a minute, let Joost answer, I think. He's with us.
Well, can you hear me now or not?
Yes, yes.
Oh, perfect. Oh, glad, because I thought I'm missing the window of opportunity here. No, so yeah, it's a really important question. How can we optimize the assessment and also assess the neurological improvement? I'm turning on my video whilst I speak, so I hope my audio is not falling away. So we've done a lot of work on the role of the Asia impairment scale and the Asia classification. And you may recall the functional prediction rule that we published, which was only based on 4 neurological factors. So you might consider a similar way of assessing the earliest neurological status, let's say in the emergency room, where you get only 2 motor scores, and as to Waggy's point, pinprick examination also has a predictive function similar to light touch. So if you get a very minimal assessment that you could even perhaps consider to be done at stage by a allied healthcare professional to say, well, is there a indication of spinal cord injury? That will be tremendously overcoming the limitation of the age impairment scale classification as we know now. So what we have seen with the Frankel, there is some criticism in terms of subjectivity. So what is useful? So that's why the Asia international classification was instated to make it much more objective in a way. But at the same time, it comes with a lot of additional limitations. So yes, we're not there yet, and we can definitely improve the way how we measure therapeutic response in acute spinal cord injury.
Thanks very much, Yus. That's very interesting. I think we're being encouraged by Henry to move on to the next session. So I'd like to thank our two speakers very much. I apologize, Yus. I think it's my fault. I cut off a minute of your talk in time I thought trying to log on. I'd like to thank the organizer for BritSpine for inviting me and the speakers, and I hope you all enjoy the rest of the meeting. Thank you very much for attending. Thank you.
Thank you.